Hello, thank you everyone for joining our webinar today. I'm Justin Venieri, Senior Director of Communications and Content at Capital RX, and we've got a good group here already. 1:02 p.m. Eastern. So if you're here for PBM Procurement Decoded, Capital RX's webinar, you're in the right place. We're excited that you can join us for this. This is a fun discussion. Kristen and Mike are amazing. I've seen them do this live. I know, Mike, you're going to be at IFEVP later this year, I think in Hawaii, right? Similar.
Yes.
Um, um, and then, obviously this is a topic that's near and dear to everyone's heart. And we think things are improving pretty rapidly in the industry with regard to the modeling of and comparison of pharmacy benefit managers during the procurement process. But I think you're going to like this one. And we hope it'll be helpful to you, whether you're a prospective client, channel partner, working with clients, and just keeping an eye out for, common um, gameplay or just pitfalls, and maybe you can improve your process and have some takeaways from it. So, for those of you who were on at the top of the hour, this is CapRx's PBM Procurement Decoded, Insights from a Pharmacist and Actuary. The housekeeping items are quick. There will be a replay. We will include a link to the slides. We'll also send an email out with a thank you and a surprise, so keep an eye out for that. There is a Q&A box. It's at the bottom of the screen per normal Zoom webinar. Just hit that if you want to ask us a question. We'll try to either work it in or make sure we get to it at the end. We have 45 minutes, so I'm going to stop talking and turn it over to Mike to kick things off. Mike, take it away.
Thanks, Justin. Good afternoon, everyone. My name is Mike Mealy. I am a health actuary by training. I say that I'm a recovering actuary because I mostly am involved with the selling process and working with consultants and brokers around the country. So I've been at Capital RX a while. I'm one of the first employees. So I just finished 7 years. I can't believe I've been here that long. Prior to that, I was at Arthur J. Gallagher and a number of other large consulting firms. I always say I'm not a PBM person, but I always seem to get involved with PBM services. Not too many actuaries do this kind of work. And with that, I will pass to Kristen. Kristen and I are the original actuary and pharmacist team. I've seen a few copycats running around, and I think we're on to a good mix. So, Kristen?
Thank you so much, Mike. We promise this will be very exciting as a pharmacist and actuary can make this. Like Mike, I was in consulting for many, many years. And I think both Mike and I came to the epiphany one day that the PBMs were just always one step ahead of us. And we were always kind of working on Fortune 500 companies, negotiating better deals, but yet our clients just kept spending more and more money, and there was kind of some arbitrary smoke signals from PBM saying what it was. But a lot of it, and we both realized this around the same time, more than 10 years ago, it was more to do with drug mix than it was discounts and rebates. So we are going to dig deep into that. As a pharmacist, I spent most of my career trying to make PBMs behave from the other side, and I actually gave up on the industry and went into digital front door land. And when AJ started Capital RX, I wanted to join the team because I do believe we have made a tremendous impact. And so, one small, sales slide so that you guys, know what our DNA is for those that are less familiar. I saw lots of great names, friends, and new friends on this webinar that signed up. Capital RX started in this industry to change the way healthcare used to say drugs are priced because we have expanded our mission and patients are serviced to create enduring social change because we don't believe anybody should be taken advantage of at the register for the most access healthcare benefit. And we realized on this journey for the last 8 years that by building Judy, our own claims adjudication platform, aligning singularly to our clients, that we were producing better financial results and also providing much better service for members. So that's your only sales slide today. The rest of it will be super educational from our point of view. And most of you are probably here because the same reasons that the Capital RX team is here, frustrated with the existing marketplace of financial opacity, price discrimination, misaligned economics between the PBMs and their buyers. operational inefficiency. We've all tried to make plan design changes and they goes into the black hole and they tell you 30 to 90 days later you can make that change. And the small market was really been very abused in this industry. So Capital RX really set out to change these with a public ledger using NADAC-based pricing, unified pricing across all customers that anybody could have access to, and aligned economics. And most of this discussion today will be about those aligned economics and the things that are driving 50% to 75% of total cost are not discounts, rebates, and admin fees. So we're going to dig really deep on that today. And we're super excited to be here. And thanks for taking your time with us. And I'll turn it back to Mike.
So this is supposed to be a funny slide, not funny, haha, funny, sad. And so I'm speaking to the buyers in the room and the consultants. I don't know how many actuaries are here, but when 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 a PBM procurement RFP is done, oftentimes the consultant will make some caveats, but they will say this PBM will save you this much money, this PBM will save you that much money. Even the same PBM that they have now will save them money. And I always scratch my head with that one, but because the discounts and the rebates get better and better, and let's just say that a typical RFP will produce a 17% savings. Now, the better consultants out there, and there's a lot of great consultants, so I don't mean to offend, but the good consultants say, don't really count that as savings. Think of it as a relative value. And I think a lot of buyers scratch their heads and say, well, it sounds like savings. You said savings. But it really means that if everything was the same as it was last year, except the pricing, you would save 17%. So the funny part about this is that when a decision gets made and then the actuaries have to set a budget, they look at all that and they say, okay, I'm going to put 5% trend on it. I'm like, what? We just told you we made a really good deal. There's going to be all this savings. And then to add more insult to injury, the stop loss carrier says, I'm going to put 9% trend on because I don't believe the actuary. And then the results come in the way they come in. So I have run procurements for the better part of 30 years. I can count on one hand before coming to Capital RX how many times a customer made a change and had a 15 to 17% reduction in their cost. And then that's when all the hand waving starts. And you say, well, there was trend. And then there was this new drug that came out and called Wegovy. Everybody wants it. And, there's always a Wegovy coming out. There's always a new drug coming out. There's always a drug going generic. So I guess the point I want to make here is that typical procurement is a static price analysis, is not a dynamic price analysis. And PBM procurement is not the only victim of this. The Congressional Budget Office does the same thing. They say, well, you can't count tariffs. They might go away. They're not legislated. We collected like $25 billion last month in tariffs, but you can't budget for that. So same kind of challenge. Next slide, please.
And I think the other challenge that we've seen is the PBMs have formed into this kind of, I'd call it a toxic amoeba, and you could never find the money because they started owning everything from retail to mail to white labeling to aggregators to health plans. So no wonder it's so hard to find what am I really paying for the administration of prescription drugs?
So I don't know if any of you saw the interrogation of PBM executives. It was several months ago on Capitol Hill. This is a real problem. We call it the price gouging. And in this particular example, there was a drug called abiraterone acetate. Frequently, and this is a homework assignment for you all in the audience, go look at your data and see what you pay, what you were charged for abiraterone acetate. It should be about $55, but it is frequently in the $3,000 to $5,000 range. Yes, 6,300% higher than and Teriflunomide is another classic. It's the basis of the original J&J lawsuit that was charging $12,000 for a literally $100 drug. Next slide. So there was a study done that if you just took those two generic drugs in that previous slide, because apparently Medicare overpays for this as well. So this is kind of a note for the Doge people. Just those two generic drugs, if they priced that at what we would charge in our network, there would be $1.6 billion in savings. So this doesn't drive Medicare's costs. I don't want anybody to think that this is a smoking gun, but this is the basis of a lot of litigation. And I believe the next slide talks about some of the lawsuits out there.
Yeah, and I was going to just add the very third bullet on here. What the FTC also uncovered was that PBMs, and this is where we're going to start getting into the meat of this presentation, may be expediting PA approvals, which is drug mix, right? Which drugs are approved? Is it a generic drug, a brand drug, or a specialty drug when patients fill at their own pharmacy? So I like to say that the pricing, that the lawsuits that we're seeing around ERISA, on to Mike's next slide here, I like to say the pricing is the tip of the iceberg. That's actually something pretty easy to identify, that NADAC is 38,000% cheaper than AWP. And that last bullet around PA approval rate, that it may be faster at their own pharmacies. Now you're starting to see the base of the iceberg. If Mike, if you want to cover the rest of these lightly.
Yeah, I mean, a lot of people have talked about the J&J lawsuit. In its original form, it was rejected. It's being refiled, or it's been refiled. But and I'm not an expert in the litigation field, but what I understand is these lawsuits seem to build on each other, and the lawyers are figuring out how to build a very compelling case against you, the employer. So that's the really sad part about all this. You are holding the bag for these decisions that you make. And you may say, well, I hired a consultant and they gave me, they were an expert and they gave me advice. But you, the employer, are responsible because you are the fiduciary.
And I think back to the FTC investigations and the lawsuits, they're just scratching the top of the iceberg, which is on the far left-hand side of this, which is the unit cost. Because again, it's easy to see. And this is what every spreadsheet's been looking at for the last 20, 30 years. If you look at the typical pharmacy procurement, they will have 300 to 600 questions on what is a brand and what's a generic, how are you collecting the discount? Do you prefer brands over generics ever? Drug classification. That's the left-hand side. The consulting community, the procurement of this has been pretty strong, and a lot of practice over many years. What's been historically underweighted that the government hasn't caught up to, and plan sponsors are feeling it, back to that funny slide that Mike talked about, that they keep getting these promises of double-digit savings, yet their costs keep going up. It's this drug mix. What is the formulary? How rigorous are the clinical programs? What is auto refilled? Does the PBM fill the highest cost tablet over a capsule because they can and it benefits them? It's back to that misalignment. When PBMs make money from pharma, and when PBMs make money off of the spread at their network or own a pharmacy, they have very strong reasons to dispense more of the most expensive drugs. So this drug mix center orange box is really where we're going to spend our time today. And that is how you get to PMPM. Your fifth grader should be able to do the math. What did you spend last year minus the rebates divided by your total membership? And once you've made a PBM move, or if you're with your same PBM, how much did you spend the next year, is quite simply what did you pay minus rebates divided by your membership. It's not that hard, but it's this middle box that gets hard to evaluate. And so we're going to cover that. So we put together this pie chart for people. Unit cost, which was the far left, so discounts, admin fees, rebates, that's about 30% of the cost of your future costs if you had to break it down. And what's getting mixed here? So let's add some other areas that you may not have considered. So number one, white labeling, repackaging. When the PBM has the full authority to decide what the cost of the drug is, that's generally not a good situation for the ultimate payer. Baseline trend. There are different PBMs out there. We happen to use NADAC, which trends at a different rate. It actually is deflationary compared to AWP. Does that get incorporated into the modeling going forward? AWP versus NADAC actual costs. Mike covered that already. Those things are very rarely fleshed out in a procurement. So you can say, okay, I know I'm buying from a NADAC bench mark, which it correlates to the real cost of the drug. The cost of the drug will be the same from the East Coast to the West Coast. It behaves the same for brands and generics. It cannot be manipulated by pharma or a PBM. It's free and accessible, and it's managed by an objective third party, which happens to be the government. Those are things that sometimes don't make it into a spreadsheet on the financial value of that. Full pass through a rebate value of I graduated pharmacy school in 2000, and every year rebates went up until this year. This is the first year I have not seen the rebates move up and up and up. This is the first year I've seen them contract a little because of Humira, primarily. That's the primary reason it's contracted. Full pass-through rebate, so all clients would get the value of that. Is that going through, and what is the future value of that to you as a customer? Coupon program fees. Some PBMs charge 20 to 30% of the value of those coupons. It's a philosophical principle of ours that we don't make money on drugs, so we charge a flat admin fee there. So with doing that, it's a much smaller percentage of the total value. And so these are also things that can be missed on the spreadsheet. We're not even to drug mix yet. This is the other 20%. And then, of course, ancillary program fees. That 7-page list of a la carte things you can buy often gets missed and can be quite variable between PBMs. So what we really want to talk about here today is looking at, whoops, drug mix, if I get my computer going forward here. And what are those things? That's the other 50% of the pie. And drug mix is really that refill logic. And we're going to show you some examples of that. Formulary. Is it a high cost formulary that maximizes rebates, or is it a low cost formulary? Prior authorization. Is everything approved? Does it feel like a rubber stamp? Is there validation of someone's condition versus attestation? The difference there being, is it a front office person just saying rubber stamp, yes? Of course, they had diabetes, give them the next more expensive medication or the next specialty drug. And then clinical programs outside of prior authorization like STEP and quantity limits. So we wanted to show you some tangible examples that you don't need to be a pharmacist or actuary, although I think Mike should get his I think he should get his actuary or his pharmacy license just because he can say all the drug names. That's starting place one. So here's a very simple example. This is not about shifting drugs. We see this data all the time from particularly the big three that are out there. And what you're looking at is one Humira utilizer, one pen that utilizes it over a year. The light blue boxes are what the PBM allows the patient to refill their medication. So you're seeing 7 days extra early, 7 days extra early, 7 days extra early, and so on. At one point, they had a 13-day early refill supply. Maybe they went on vacation. So this one member had 88 extra days of Humira, costing the plan $38,000. Because we're aligned only to the customer and because what we feel is we're clinically appropriate, we have auto refill logic or smart logic, intelligent logic that turns on, and we feel that most patients are very happy with 14 extra days on hand of their medication. So this is a program that our, employers can elect into, or union or government can elect into. And over the course of the year, that same member, instead of having 88 extra days of therapy, only has 14, and it only costs the plan $6,500. So this is a great example of how PBMs can inflate the healthcare balloon or contract it. We didn't change the drug. We just didn't auto refill them to death. And that's what I would say. And I think we've probably all experienced the text messages in this modern day of these refills coming. Another great example, we're starting to get a little more clinical, but I don't think you need a clinical degree to understand this one. These medications for weight loss or diabetes being filled on the same member, again, data that we get from other people when we're running RFPs, and they're filling both Ozempic and Mounjaro. There's no clinical reason, and anybody who's taken those medications know that if you doubled up this dose and took two medications, the side effects would be pretty rough to deal with. So again, where was the pharmacy benefit management in keeping this person safe? This really allowed the PBM to make more money, but this wasn't, I would say, clinically appropriate to fill two GLP-1s at once. Another way, and this is all at the plan, the union, the employer's discretion. Another thing that we would look at, and we get data, many members, these are individual members that we receive where they filled one GLP-1 and they never filled again. Maybe they needed better counseling, but this is a complete waste of money. So we recommend to our customers fill 30-day supply or even 14-day supply. Let's let them titrate to the right dose and make sure that they're going to stay on the medication because this is, the odds that they took all 84 days and then never took it again is slim and none. The most likely scenario in this data that we're looking at is the side effects were too much and they didn't want to deal with it again and they never took it. So this is what we would say is 3 months of wasted therapy. And I'm going to turn it back over to Mike because he's going to go through the same concepts of drug mix, but at a very higher level in a spreadsheet because I know there's some serious math people, less pharmacist friendly there here.
So what we get as a criticism in the market is, well, you're talking about all of these things because your rebates aren't as good as the big guys. And okay, I'll give you that. I mean, we get our rebates from the big guys. So I guess they're right. The so even conceding the point in this example, we're saying, look, let's say that and again, I don't mean this to be an infomercial for Capital RX. There are a number of PBMs that are our size that also have this same phenomenon. So we're not the only ones that have this effect. So let's say we have slightly less rebates. So that's the example up top. But our entire book of business, we approve 67% of high cost specialty drugs. So before you say, whoa, 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 you're denying claims, we have also very high net promoter scores. Our customers are very happy with us. Our members are happy as well. But we do only approve about 67% of high cost drugs. The industry's at 90. Now, remember, specialty drugs are half of your budget. So if you play this out, we're going to be approving less high cost drugs. We're also going to be getting less rebates. So in this example, the legacy PBM is at 28 million in drug costs, and we're down. We're at 20. But wait, we also don't have as much rebates. So that $12 million rebate on the left goes down to 8 million. But at the end of the day, do you really care? This is $3 million better to do it this way. Members are happy. They're not being over medicated. Nobody's got their pitchforks out. So I think this is a better way to manage your program than to just let everybody have everything they want. They just have to run around the building twice and then they can get it.
And I think this is what
Can you go to the
they
next slide?
haven't figured. I think they haven't figured this out with the investigations. They just that last third bullet where it said, oh, they have higher PA approval rates at their own pharmacies. They're just starting to scratch the surface. The government, the investigations, the RISA plans. Right now, they're focused on price, just like procurement has historically been focused on price. And if you look at this spreadsheet, think about this, the way you've always awarded PBM business, you would pick the one on the left because you're like, look at these rebates. They won the deal. And they haven't thought about this middle bucket of approval rates and the auto refill bucket. This is a very simple example, but people are starting to wake up and wonder what's happening.
So we actually have a way to model this for you. So if you were interested in saying, hey, would I save that much money in my plan, well, we'd have to collect some information from your incumbent PBM. And, I challenge the industry to ask me a question that's not about unit cost. Ask me about PAs. Ask me what happens when we deny a claim. How many times does somebody get their pitchfork out? How many times does somebody appeal it? You'd be surprised at the statistics. There's side effects with every drug that you take. So if the best drug is no drug at all, if it's not necessary. So we actually will go in and model. Every group is different. In the examples Kristen had, the refill too soon was quite a substantial savings. And in this particular example, refill too soon was worth 0.4%. So this wasn't happening a lot in this example. Formulary shift is when we model what would happen to your members if they were with our formulary. And so we can model the cost savings from that. Quantity limits sounds like kind of a boring thing, but um, there's a lot of wastage by approving a 90-day fill day one. We recommend not to do that. We say start them out with 30 days or 14 days. So we go line by line, and again, if these questions are not in your procurement, you should be asking your consultant, why are they not there? Now, I already know the answer they're going to give you. The bad answer is, well, because we always do it that way. And trust me, I know what I'm doing. But the better answer is, and I really do empathize with the consulting community, none of these things are guaranteed. So why? Because there might be a group that needs an 80% approval rate. You just don't know when you see a patient until you go through the process. So we have groups that have 50% PA approval rate. A lot of unnecessary drugs get prescribed in that group. So it really does vary, which makes it challenging. So because the PBM industry is so untrustworthy, consultants have been, sort of boxed in that they have to get a guarantee out of everything. And I think that has to change as we evolve. And uh, this is another way to think about it. If you are getting lots and lots of rebates, you're probably going to be spending lots of more money in the future. So when somebody says to me, "Oh, Mike, you were 2 million behind on rebates," I'm like, "Was I? Um, what was the projected increase in cost?" "Oh, well, we held everything static." This is back to my static versus dynamic calculation. So if somebody is offering 2 or 3, or let's say if rebates are vary more than 5 or 10% between a PBM, something is askew. And for that matter, if you're running a bid and everybody seems to be clustered around the same number, but one guy is 20% better or worse, there is a problem. Something isn't being valued correctly. The industry is pretty tight with respect to pricing, so you should expect most offers to be very, very close to each other.
I think that's worth doubling down on. On the unit price analysis, there is no such thing as a 10 to 20% delta between PBMs. And that's because the GPOs have sold off their rebates at such an aggressive premium. So if you ever see a 10 to 20% delta on just a unit rate card analysis, something is wrong. The biosimilar shift, the shift in ingredient costs to rebates, the way they're counting it, anytime you see it, it should be a red flag. So I like to call this slide the reverse fiduciary test. If you start seeing a massive rebate, win from some one PBM, you should scratch your head. And you also should realize there's no free rides in life. If you see a massive rebate number there, you have to spend money to earn the rebates. There's no free rebates. So super important to think of things in reverse as that we normally do. And this is what we normally say when we go from the traditional model all the way over to the Capital RX model. There was an incredible EBN article about 3 weeks ago from Rice University where the client stated after being with us for a year and during that year deciding to cover weight loss, she had a negative 5% trend. So previously she hadn't covered weight loss meds. She did cover. So how did Capital RX do that? One is 100% of that pharma revenue. And we all know that pharma has been really good and PBMs have been really good at reclassifying what pharma revenue is. So there's all kinds of different buckets, but every penny goes back to our customers, and one customer doesn't subsidize another customer. NADAC, I think we hit that pretty hard on. It's really a cost plus model on a unbiased partner or government survey that's out there of what retailers actually buy the drug for. Low value drug optimization, is that formulary a high cost formulary or low cost formulary? How are you measuring that in your procurement? And what are their prior authorization rates? And then, of course, the refill example that we showed you, and specialty cost optimization. 2% of claims drive 50% of spend. If you are not doing a deep dive on what specialty drugs are filled and how much of them, you're really kind of missing what your future costs will be while you're doing this procurement process.
So the good news is, as the buyer, armed with this information, all you need to do is go back and beat up your consultant some more. Uh, Krista and I were talking about this before we started. We think that about 30 or 40% of the consultants out there are addressing these six issues. So they're looking at the difference in trend rates between AWP and NADAC. These are very substantial differences. Uh, what about low value drugs? And I'm sure everybody's heard of the drug Duexis. And like, yeah, we've heard that 100 times, yet it's still in claims data. Somebody's still filling this stuff. So for those of you that don't know what Duexis is, it's Advil and Pepcid mixed together, and it's only $2,000. But don't worry, it's got a really big rebate. So you don't want that drug. You don't want to approve that drug. It's not we call it a dumb drug. It's not good. Compare the PA success rates. As I said before, Capital X is not the only one that's doing this right. What's interesting is big PBMs, when they're doing Medicare Advantage plans, also run at 67%. So when the government is watching you, why are they approving 67% of high cost drugs? But when the government's not watching you, you're at 90. Riddle me that one. Are Medicare people just more receptive to denials? I don't know. The fourth one is auto refill. Like I said, it's not always the smoking gun. In the example we had, it really wasn't a big deal. Sometimes it can be a really big deal. Copay cards are also a very confusing subject. It can be 6 to 8% of drug spend. And so it's important that you understand how your PBM is being compensated from that program. And last but not least, and this is our founder's pet peeve, he said you really don't know what you're paying till you pull the invoices, because the claims run may or may not be the perfect source of truth, but the invoices are. So it's just another simple step. You have them, get them from your finance department. They don't just pay whatever the PBM wants. There's an invoice that goes with every bill. And the next slide is just to make this a visual. Again, actuaries and pharmacists, we're trying to be funny. So would you drive half a car? When you run a PBM procurement that's only looking at unit costs, that is what you are doing. And again, I'm guilty of this. I did this when I was at Gallagher, and Kristen, I'm sure you did this in your life. We said, let's assume everything else stays the same, and let's just focus on the price. And then now for the health and welfare people out there on the medical side, not to pick on network discounts, but how do you do a network evaluation of Aetna versus Cigna versus a Blue Cross plan? It's pretty much the same problem. You're saying, well, Blue Cross has a better discount, so I'm going to go with them. Well, what about all the other things that go into a medical carrier? It's the same kind of a calculus. So that concludes our presentation. Thank you so much for enduring our session, and we've got time for some questions.
Yeah, we had a few questions come in on prior auth, so we're gonna get to those right now and address them. I'll bundle two of them together just to make it a little easier, and then I have two follow-ups for you. I think I'll just start with you, Kristen. from Scott. Your PA approval rates are much lower than the industry. Were those patients migrated to other lower cost meds or simply denied? And I'll add on, given an anonymous question that came in, what are the most frequent reasons for denial and how do you manage this to keep members largely happy?
Most of them are moved to a lower cost alternative. And the reason, to Mike's point, that we keep our net promoter score so high is that one, we talk to their physician and then we collaborate with the patient. Say, we talk to your physician and he or she is in agreement that you could try this other medication. What we typically find as clinicians is that unfortunately, these commercials on TV or Dr. Google, if you go ask your doctor, 80% of the time they will write that new specialty medication that they sell on TV. Otherwise, pharma would not advertise on TV. It wouldn't work. And a lot of times, maybe it's eczema and you have a very small patch of eczema. When we start talking to the patient and saying, you know, you've never tried a topical cream that costs you less and it doesn't have the side effect profile. This other specialty medication that you saw and was originally prescribed, you could have a higher risk of cancer or you could lose your hearing. Patients are very receptive to that information when they know that they're talking to a clinician who's been collaborating with their doctor. And it's also the speed to which we do it. So industry average is 7 to 10 days on turnaround time for prior authorization. Ours is 2 to 3 days. So if you're talking with authority and clinical knowledge and you're doing it quickly, you alleviate a lot of the, I think, struggle and the dissatisfaction that we've had in healthcare. Also, I have to say, we're really lucky. Our customer care team, 91% of the first line call center are technicians, certified technicians. So they know how to pronounce the drug and they feel good. And if a member says, I want to talk to a pharmacist, or if it's a denial, in that case, they would be talking to a pharmacist. That's 8 seconds. So it's those sort of decisions. But yes, we don't make them walk away with no drug. Our net promoter scores would be awful if that happened. It is very much about getting them to a first line agent if they've never tried it. But let me tell you, if they did have a severe condition, we would absolutely say, okay, their body's covered in eczema. We're not going to make them slather themselves in some sort of cream. You're going to give them the specialty medication because their clinical criteria gets there. I was fortunate enough to be part of a finalist meeting the other week, and someone had had a Capital RX child who then came off the plan and went to a big three, and they're like, it was so easy to get the specialty drug with you all. It's been awful with the big three for my 25-year-old that's not on the plan anymore. And so I know sometimes that 67%, which is an average, some people are higher, some people are lower, depends on the mix of your population. That's how we get to an average. It seems to be pushing up a little bit more with the GLP-1s because they are appropriate, but and for so many people fitting the criteria. But I think it's really important to know that they are getting the medications, they have good clinical messaging, it's done in a timely manner, and that's how you get patient trust.
Uh, and if you can peel back just reasons for denial a little bit, I know it's sometimes there's an error, sometimes it could just be it's just the plan design. What are the most common reasons for a denial in that bucket?
Denials is often medical necessity is missing. That's probably one of the big ones that if it's ever an appeal that gets to that point, it's because the doctor wasn't paying attention. We couldn't get the office clerk. The other ones really are, they just didn't meet the medical criteria. And back to my statement earlier, 80% of the time, if you're not asking for narcotics from your doctor, they will write that script that you saw on TV. They just will. And so if you don't meet that medical criteria, you don't want to start with a drug that less than 3% of people. The funny story on stomach and ulcer medications, which we used to call, purple crack out there, it started with Prilosec, right? We all had Zantac and Pepcid. It pretty much worked for us. And then Prilosec or Omeprazole came out on the market. Everybody started taking that, and Nexium and all of those. Those drugs are really meant to be taken for 6 to 8 weeks for most people. There's very rare conditions where you need to take it every day for the rest of your life. And we've learned a lot over 20 years of the side effects and the implications of those medications. So, medicine is, part art, part, it's not all science all the time. We don't instantly know how it's going to react in every person. And so it takes many years. So if you can avoid taking something that less than 3% of the population has taken and has side effects, you want to start with the first line therapy that lots of people have taken and we know it's safer. And that's just, how most people want to treat their families or how I would treat my family member.
Right.
Okay.
One thing to add too is we're not inventing our own criteria. We're following FDA guidelines. So how is it
Mhm.
that we approve less than everybody else? Well, it's because we follow the guidelines to the letter of the law. And a great example of that would be Ozempic. So we're not talking about weight loss for a second. So a lot of plans don't cover drugs like Ozempic for weight loss, but you're a diabetic, right? Wink, wink, nod, nod. If you're a diabetic and you have the BMI criteria, you can qualify for Ozempic. We make the doctors attest that the patient is a diabetic. We don't say, well, the nurse said they were, and that's good enough. And we also often want to see lab charts, like show me the A1C. So we are following the rules. So we're not being mean. We are following the rules as they were written.
Got it. And there are a bunch of other questions coming on PA, but I think we're kind of answering them in various ways. I'll work them in if we can. But a little different spin here, NADAC. Isn't NADAC a voluntary reporting? How do you verify that it is the proper sample size or truly reflective of all pharmacies? So maybe if you could take a minute, Kristen,
I
or
love that
Mike,
question. I
yep,
love
and
that
just
question.
explain a little bit more about NADAC and
Ooh, NADAC's bad, bad. Get rid of it. So I've done these, in public settings. I'm like, come on, bring it on, bring me more. I could talk for an hour about how horrible NADAC is. It doesn't do this and it doesn't do that. Not every drug has a NADAC. The big guys don't report NADAC. Yet, what is the alternative to NADAC? AWP? And that's somehow a good thing. We have a joke in our industry that AWP stands for ain't what's paid. So we think that NADAC is a better index. It is deflating. It has been volatile in recent months. And we think that's because somebody's jumping in and jumping out and reporting. No, we don't know for sure. But we think that is just a better index to use versus AWP.
But I will joke the volatility. So where AWP doesn't deflate at all, it's just straight, right? NADAC is deflationary. So the volatility, instead of it being negative 15 to 10%, there was some months where it was negative 5% for some drugs. So I was like, what do you want? Do you want zero, flat? Or do you want somewhere between negative 5 and negative 15? So that volatility is still much better than what AWP was doing. And you don't want a price source that the PBMs can manipulate. Think about how you buy milk. We have a great little article on this. When you go down the aisle, which bottle of milk do you buy? The one that says a 90% discount or the one that says 87% discount and take to the counter? What's going to be cheaper? You don't know because you don't know what the starting price of the drug is. It is absolutely ludicrous that we purchase drugs over an effective rate the entire year. NADAC can be audited on an individual claim basis, and the price source can't be manipulated. So it is a much better, safer price source that each claim can be audited for accuracy that's out there, and it's deflationary. So I do see a lot of regulation out there or legislation that's being pushed forward towards NADAC, which I think is very interesting and telling.
It is also risk reducing. You're less likely to get a J&J lawsuit if you're using NADAC as a price index because there is no way that you can charge $12,000 for teriflunomide. It's $55.
And it
That's
is,
the
I do see one of the chats, it is voluntary reporting, but all the retail pharmacies, except for the three of the big ones, really report and mail order don't report. And the supply chain is very tight. So, yes, do the big box buy a little bit of a bulk discount? And are they getting a little bit more premium? And the irony here is generally their dispensing fees are higher, even though they're buying at a lower discount. So, because all of these pharmacies are surveyed and they respond to the government every month. This is what they buy the drugs for at the wholesaler. And it is a very tight supply chain. So, do a few big guys get a little extra? Yeah, but are drugs sold wildly different pricing between an independent pharmacy and a big box? It's not wild. And for the big boxes, there's still the cash price. So you get the lower of logic or the cash price. So if they are giving a $3, $2, $4 generics program, that's going to be considered a cash price. If it happens to be lower than NADAC, they get the value of the cash price, no matter where they are. Big box or, Walmart was the most famous of those. So it is still a lower of logic situation. So if anybody wants to beat it out there, beat NADAC, great at the big box, and they could be more competitive in the marketplace. But the big guys generally don't try to be more competitive.
We got another good one. We're kind of out of time, so I hope we can bear with us here. But this is a good one on the auto refill issue. What's the best way to mitigate the cumulative excess drug supply? Most plans, I would imagine, have a refill too soon edit. Are they simply too liberal? Is the question.
They're simply too liberal. They're turned on at, you can refill at 75% complete. And that's how you see that slide that had 7 extra early days, 7 extra early days, 7 extra early days. And over a year, that ended up being 88 days of supply. So the best thing to do, the system has to be smart enough. And most of the systems that PBMs run on, except for ours, were built in the 90s or early 2000s. So they don't have this like logic or technology capability to do a look back over a 6 month period to say, does that member have 14-day supplies on hand? You're asking, you're asking old Bessie to be a Ferrari. Old Bessie, the old adjudication platforms that were very steady, they can't do what our adjudication platform can do.
Okay. And if I can squeak one more in here, is that cool?
Yeah.
All right.
We
Um,
could do this all day.
This is probably more
so
fun.
the Q&A is always great. So from Christian, is the 2 to 3 day PA approval length for CapRx new? I was with a client 6 months ago, and the turnaround time was 7 to 10 days, sometimes 14 days. I think there varying ranges for the turnaround time based on the
Yeah,
requirements or
the
how.
biggest
But
variable is the doctor not cooperating. So we've had many times the doctor says, I'm just not doing this. Like, okay, then your patient isn't getting the drug. So this assumes that we can get a hold of the physician and get through things, but sometimes they do hold up the process.
I have to answer this one more question. If I won't say who they're calling to the mats is returning 100% of all rebates, what else are you leaving on the table? They've reclassified what rebates are, so they can tell you, I'm giving you 100% of your rebates, but then they call them value-based rebates. They call them other things, and they have formulary access fees. So there's 7 different buckets that pharma and PBMs have reclassified and named so they can look you in the face and say, I'm giving you 100%. The question is all pharma revenue, which even includes educational programs if they're using educational programs with doctors. I didn't want to leave that one because that is one of the sneakiest ones they do.
Right. I mean, I have a funny story to share there too. We one of our finance people said after we settled the 2023 rebates, in the summer of 24, uh, in November we started getting some checks, like some pretty big checks, like $45 million. I'm like, what's this? Oh, this is the extra payment for the reconciliation. So basically, we had already settled all of our rebate guarantees, and there was this extra, 40 something million, and there was another 10 million in value-based rebates. So we, of course, divided it up amongst our customers and passed it through as additional. Like, we already met all our guarantees, but here's more money. We think many PBMs keep that money because you've already settled your deal. It's like this is like 3 months after you settle. So there's always money coming in somewhere from drug companies. And the question is, what do you do with it?
And for those of you who were not anonymous in our chat, we will try to email you and answer you on all those questions that have come in. And I think Justin has a bonus for you.
we have we have one more from Rick. Can you discuss your copay strategies to reduce patient cost when coupons are utilized? I'm sorry, when coupons are utilized, how does CapRx address this?
It's
Well, that's an interesting
depend.
question. Yeah, in a high deductible plan, we believe that if you get $1,000 coupon, that should not goes towards satisfying your deductible. So we can go either way, depending on how the plan wants to do it. But I think that's the best example of how our technology is very capable in that area.
Okay. All right. Well, thank you, Kristen and Mike. And thank you everyone in the audience for your questions and sticking with us over time here. We hope everybody has a great rest of the day. Keep an eye out for the follow-up email, and we will get the replay and the slides up and available. So
We
thank
appreciate
you
your
all.
time. Thank you.
Thank you very much.